thank you so much for joining me today. I think
Of
this is
course,
going
Gail, wouldn't miss it. Wouldn't miss it.
this is going to be an amazing conversation, as all of my conversations with you are, and we have no idea where it will go, which is the
There is
best
zero
part.
script. People don't believe us, but I literally don't even know what you're going to talk about. So,
Well, neither do I, so that makes two of us. Well, it's just really great to see you and catch up, but I think we could probably have a series of podcasts with you because we could
let's do
cover,
it. Let's do it.
yeah, I love that. Really appreciate that. We could cover anything from ENT, allergies, sleep apnea to business to family to, I mean, just amazing stuff.
Yeah. Well, I tell
So
people all the time, it's amazing that you and I operated literally in the rooms next door to each other at the same hospital 20 years ago and barely
I
knew
know
each other.
it's
And
like our
then,
little secret.
right. And then reconnected further down our career paths over different things. And I'm glad we did.
Me too. I love that. I think what that speaks to is the value of building good relationships in work. You know, people who you really trust and respect and enjoy. Um, I think those people stay in your life for a long
Totally
time.
agree. Well said. Well
Yeah.
said.
Same for mentors. Love to do a whole series on mentors. But since we're here, let's start with you. Um, I would love to know a little bit more about how you got into ENT, because believe it or not, even though I've known you for 20 years, I don't know that part of the story.
Yeah.
And I'd love to, I know you're really passionate about what you do and you're really skilled and an expert in ENT.
Thank you.
So I'd love to know how that all started, how you got inspired.
Thank you for asking. Yeah, a lot of people don't know that. So I'm glad to
Mhm.
share. So early on, I would say by high school, I was very interested in medicine, but I was still, had the pipe dream of being a professional baseball player. You know a little bit about that with your worst half, right? And so, being the young hotshot that I thought I was, I thought, well, whenever I'm done playing, then I'll go to medical school and be an orthopedic surgeon. And
Now that makes sense. I can
I'll
see you
be
as an
the,
orthopedic surgeon.
well, I'll take that as a compliment. I'll take it. I'm not trying to bash ortho. I'm just playing around. So, I thought, yeah, I'll be the shoulder and elbow guy. And while that would have been wonderful, I mean, from what I know, even now, once I did go to medical school, the way at least my curriculum was, and I went to McGovern Medical School in Houston, University of Texas, wonderful, wonderful institution in the Texas Medical Center. The way they organized our curriculum is we did blocks of material based on the anatomy. So I think our second block of material was the head and neck. So histology and physiology and pharmacology, gross anatomy, all of that was tied together. It was a really nice way to learn it. And I was fascinated by the intricacy of the head and neck anatomy. So that made me pause a little bit about the ortho plan. Again, I'm a freshman medical student, so everything is interesting. And but I started to watch ear, nose, and throat procedures, which I didn't know much about. When I was, I think, 5 or 6 years old, I had my tonsils out. A couple years before that, I had ear tubes, but had no other contact with an otolaryngologist from that time through medical school. Now, this is a long time ago, right? This is well over 30 years ago, so the specialty is completely different. But what has stayed the same was the variety. So I noticed, first of all, I liked the people, the faculty members of my medical school that chose ENT for themselves and their careers. I noticed that it was even back then, this is in the early to mid 90s, it was a specialty where there was good female representation. From a patient standpoint, there was also quite a bit of variety. I saw, cases with premature infants all the way up to the elderly, males, females, all kinds of different disease states. Uh, in general, it's about half clinic, or certainly back then it was half clinic and half operating room. That's changed a lot. In some respects, I've been able to help change that, where most things are now done in the clinic. But I felt like there was quite a bit of variety, and so that's why I chose it. And my older self is really thankful that I chose it. Not only have I enjoyed this career path, the clinical career path, but I also look at my colleagues in orthopedics, urology, some of the similar type specialties, and I'm in the ER a lot less than they are. So even from a quality of life standpoint, I made a good choice. My family time, my personal time has not been as interrupted because, as you and I well know, this is a 24/7 commitment, especially if you want to truly serve your patients and be good. And I don't know, as a hotshot medical student, you really appreciate the decision that you're making to become a physician, even now, with some attempts at limiting work hours and making it a little more tolerable. It's a life choice when you choose to become a physician. So even from that standpoint, I'm really glad that my younger self 30 years ago chose this.
Great story. I love that. And there are a couple of little gems in there that I think help me understand how we connected on a very deep level. And that is number one, you are an innovator. And you chose your profession based on the breadth of what you were seeing clinically. And ultimately, I'm sure that led to your passion in problem solving, right?
Well, thank you.
Um,
Yeah, I mean, I hadn't connected those dots, but I bet you're right. Um, yeah, there's just so much variety. It's always interesting.
yeah, there's never a dull moment, and there's always
Yeah.
something to solve. There's always a problem to solve.
Yeah.
And you're always thinking, um, and I think that we share that in terms of our different career paths, very different, but very similar in that way. My background was in anatomy and physiology, very basic. And same thing, the human body just fascinated me. And it's really interesting to hear you talk about how intricate the head and neck anatomy and physiology really is. I don't think we have even begun to understand the physiology of the nose, the oral
No, no,
pharynx.
scratching
There's,
the surface. Yeah.
oh my God, it's so embryonic, that whole field. We've kind of been, I'd love to hear your perspective on this. I mean, my perspective is kind of like, it's the hammer and nail situation. It's like, okay, you've got a nose, let's get in
Right.
there, let's do some rearranging of the plumbing.
Yeah, and obviously that worked in some of our surgical training, but in the nose in particular, um, most of us realize that what makes common sense is not really making physiologic sense.
Mhm.
And so I know you and I have talked about this a lot one on one. We used to. So my career is interesting, spanning this particular 30 to 35 years, because sinus surgery and nasal surgery in particular in the 1990s was materially the same as the 1890s. And that's not hyperbole. It really was a situation where we made large openings into the sinuses. We removed a lot of tissue, including structures called turbinates that are really valuable and should not be removed. But it was all with good intentions, trying to create more space in the nose. If the patient couldn't breathe, let's give them a lot of space. Well, we learned it's not quite that simple. When we made huge openings into the sinuses, we completely changed the atmosphere within those sinuses. And a lot of those gases that we now know are concentrated in our sinuses have antimicrobial protective activity. And when we make a nickel size or a quarter sized hole, which sometimes we still have to do, but just willy nilly doing that in everybody, we're really changing physiology and not for the better, in my opinion. Still a little bit controversial, but not as much as 10 or 20 years ago. So uh, that transition has been fascinating in my career to go from what we call big hole surgery in everybody to the majority of patients being treated with very minimally invasive techniques to try to restore natural physiology. But you're right, we're only beginning to understand that physiology, the microbiome. I think the lay public is very familiar with the GI tract and how there's so many beneficial bacteria and other flora there. Well, the nose is no different. The sinuses are very similar to the GI tract, where there are a lot of good bugs that are helping us. And we want to make sure that we preserve that balance.
Absolutely. I mean, it's been fascinating for me as a breast surgeon with, you know, really limited knowledge in the ENT space, getting into this field because it really reminds me of what breast treatment and surgery was like 30 years ago.
Right.
It really
Right.
does. And I have that same sense that, wow, there's so much work to be done, which is great for people like you and I, because, well, I mean, to some extent, a lot of people, I'm sure people ask you the same question, why are you still working? Right? And, but it's impossible to stop when you have this
Yeah.
knowledge and you have a passion for like continuing to make things better for people. It's not work to begin with. It doesn't feel like work.
Right.
You know, I
See,
wonder, do you get that?
I do. And to me, yeah, I mean, it is fun, but I almost feel like we're playing a game and we've gotten a couple clues and or you're reading a book and you're finally getting to the good part. Why would I stop now? I mean,
I know.
uh, that doesn't even occur to me or you because we're discovering things and think, oh, well, we could really develop that or learn more about that. And it's just step by step.
It is. I think it's a really interesting experience for me, and I'm curious to hear what it's like for you. In today's world, it's like people are so much just in the moment, and then they scroll past it. They can't even remember what they saw or how to get there. They don't actually even care about that.
Mhm.
Whereas we've experienced these major transitions and transformations within the medical community in our respective fields. We've been part of that. And we want to continue being part of that. But I find it harder and harder to do that because it feels like the younger generations just don't have that same commitment or interest or focus, maybe.
Yeah. Yeah, that does. I know we sound like old fuddy-duddies, but at least my younger partners, they are really fascinated with innovation and um, they still can learn things from, one of my older partners, Evenson. I know you're friends with him too. And, the young guys will ask us for our wisdom, but we ask the young guys for their perspectives, being so recently trained and studying for their boards and being so up on the latest literature. I mean, I learned just as much that way. So I definitely know what you're saying, and we all were concerned about that. This may be a little controversial to say, but whenever they did limit training
Mhm.
hours,
Absolutely.
what would happen? Would that change the work ethic? Would that change um, essentially what physicians expected out of their job and what patients could expect from physicians? I've been fortunate to work around, again, my younger partners and many young physicians who are just as hungry as we were, who view this as a calling more so than a 9 to 5. I mean, I laugh to say 9 to 5 because the what physician works 9 to 5, but even today. But I still think, and I tend to be overly optimistic, I'm sure. But there are a lot of the younger people behind us that have fought through just as much competition, if not more, to get into medical training programs and then to get into these positions, and they do view it as their mission.
That's great.
I'm
That's
glad.
great to hear.
I'm glad.
I think you're
We
closer
need
to
people
that.
to take care of us when we're
Oh,
older.
we do.
So, so we certainly want people that are similar, and I feel like I know a lot of them that are just outstanding.
Well, that brings me to another topic, which is, the whole idea of the paradigm shift to staying well as opposed to treating disease,
Yeah.
right? I mean,
Yeah.
we've seen a massive shift. I wonder, do you see that in your practice?
I still feel guilty that we're so reactive,
Mhm.
right? I mean, I literally right before we started recording, I had to dictate an addendum to an op note to make the insurance company happy with the codes that I submitted for reimbursement. I don't think the lay public understands the amount of clerical work that physicians have to do now. It's absurd. It's hours a day.
It
It's
is absurd.
it's a it's an absolute game, and we're recording this at the end of December. I don't know when it'll be live, but so Q4 is the worst of all with all those antics, right? I say all that to say though, um, I still feel even in otolaryngology that we're reacting to disease processes that we could have prevented. Case in point, we know there is good literature that people with chronic sinusitis, especially those with nasal polyposis, a subset of patients that have inflammatory polyps in their nose, if you intervene early, whatever that is, surgically or using some of these new biologic drugs, whatever, that patient is less likely to develop some of the chronic diseases like asthma. And so the evidence is very compelling for us to intervene early, but the system is not necessarily set up that way. In fact, it's set up against you intervening early. For us to be able to operate on patients, we have to document an inordinate amount of infections and antibiotics and this, that, and the other, and literally follow a cookbook. I love cooking outside of medicine, but I don't love cooking inside of medicine, and I feel like I'm following a cookbook all the time to appease a non-medical person at an insurance company so that I can take care of the patients. And I tell patients that all the time. I feel like I'm executing a plan. I don't feel like I'm getting to decide much anymore. And that's wrong because I'm the only person that's authorized to make medical decisions with my patients, right? According to our certifications and board specialty, et cetera. But so many times I feel like I'm not the one making the decision. It's the third party payer. So yeah, there's been a massive shift, to borrow your words, ideologically, but I don't know if that's what's actually happening. I still feel, at least in the Western world, we're very reactive in cardiovascular disease and dementia and on and on.
I agree with you. However, it's one of the reasons I left clinical medicine was all of the things you just mentioned, the burden of the administrative work, having to justify for an insurance company as opposed to doing what was right for the patient. I just couldn't do that anymore.
Yeah.
And
And none
I,
of us as physicians, we don't want bad actors out there. We do not want people doing unnecessary procedures. We do not want unsafe people. None of course. And maybe we should have been better at policing those types of things, although I think they were rare
I
occurrences.
think they were very rare.
But now our hands are so tied.
Time.
It,
Absolutely.
it's
I
really frustrating.
remember the straw that broke the camel's back for me was a patient who had tissue expander in for the first stage of a breast reconstruction. And the expander had deflated. And so it needed to be replaced before she could have got the second stage of the reconstruction. And her insurance company refused to let me take her to the operating room. And it just was the straw that broke the camel's back. I was
Because
like,
it was cosmetic, or I guess what was the,
no, no, they were just like, this is gonna have to go through a 30-day whatever review process and all this other stuff. Um, I managed though to, work within the system to get it done. But it was so absurd that someone who had no medical knowledge or the impact, understood the impact on the patient. They just didn't get it, you know?
Yeah.
So it was what turned on the light bulb for me, and that was a long time ago.
Well, I mean, I'm still planning to practice for the near future. I'm in my mid 50s, and so I feel like I'm still, contributing positively to patients and things. But just a month or two ago, and for fear of any repercussions, I won't say specifically which insurance company, but I mentioned Q4 earlier. As we get to this time of the year, it becomes harder and harder and harder to get anything approved. Patients come in every day and say, well, I've met my deductible doc. You know, is there any way you can do this before the end of the year because it's going to save me thousands of dollars? And what I do, you dealt with cancer, right? And that's life or death. Most of what I deal with as a rhinologist, as a sinus surgeon, is quality of life. So it can be put off, but if you put it off just until January, it's a real economic hardship on patients. Well, this particular case, I'm used to uh, the third party payers combing through records and finding some omission that, myself or my scribe or whomever might have had, and we have to clarify the documentation. But this particular case, it was a slam dunk. I mean, the CT scans, the history and physical, everything could have been the actual blueprint for the criteria by this third party payer. And somehow it was denied, my proposal for surgery. So it goes, for those that don't know, you go to peer. At least with this particular payer, I talked to another person that at one time was an otolaryngologist. Many of the payers, you talk to physicians that aren't even in your specialty. So for me, I often talk to those in psychiatry or primary care or something, and so it's real difficult to discuss surgical nuances.
It's so crazy. I
Just
don't mean
like
to laugh. It's just so crazy.
No, it's not peer to peer. And it's like those physicians talking to me about a schizophrenia diagnosis or something. I don't know. It's been 30 years since I took the test on that. And so at least this particular payer had someone that used to practice otolaryngology. And it finally came down. I mean, there was no chink in the armor per se until we got down to the CT images. And again, these were the absolute definition of the amount of inflammation and blockage that uh, they would approve surgery. And finally, this person just said, I don't see what you see on the CT scan, telling me that. And unfortunately, his word is final. And so that patient, I was not able to treat that patient. Now, they're not going to die right away from that, but they can't breathe, which means they can't sleep. They're chronically inflamed. Having chronic sinusitis is akin to having an autoimmune disease. I mean, patients are chronically inflamed and they feel that head to toe. But their payer said that, this physician didn't see what I saw in the CT scan. So, no. And it just becomes a game, really. They know that if the calendar flips, there's a high likelihood that that patient will be on a different insurance company based on their employer, or at least it will be cheaper because the patient then has their deductible and out-of-pocket responsibilities. And it's just become an actuarial game as opposed to, and this is from another physician, I mean, theoretically, one of my colleagues. And I I'm not exaggerating, between the charting, doing two or three of these phone call appeals every day. I mean, there are hours of administrative things that are put upon us that are absurd, that are silly. Um, and I hope we find a solution to that, whether it's AI or what, because so many people are concluding what you did, Gail, that I love the patients, I love doing the procedures, I feel like I'm still good enough to help people, but I don't want to fool with this. I'll put my
It's
energy
painful.
elsewhere. Yeah.
It's painful. And it's very painful to hear the frustration that you have to deal with someone who's so skilled. I mean, this is just not something that should be in your day-to-day work life. It just isn't. And I think most people don't understand what highly skilled physicians are having to go through to get them their care. And it's going to go away. It's not a sustainable model. I think the American medical system, as wonderful as it is broken in many ways. And I would love for us to put our heads together on a way to fix that. As you were talking, I thought, well, it's not really a quality of life issue for your patients. It actually is just as bad as having cancer, right?
The
So
adaptation, yeah,
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 and truly because they're not oxygenating, I'm sure, the way they need to be oxygenating. They
right.
can't think the way they need to think. They can't be productive. They're not sleeping properly. So it is a health risk. And we know that leads to higher rates of stroke and cardiovascular disease. So here's what I was
Even
thinking.
motor vehicle accidents and trauma,
Absolutely.
right? From drowsiness. You touched on it, but the brain fog, poor productivity at work. So we call that presenteeism. Yes, the patient is sitting in their desk in their cubicle at work, but they're not as productive as they could be if they had slept the night before and they could breathe while they're sitting there.
Yeah.
So, yeah, these
So
are
it
important
made
things.
me, here's what it made me think of, because you mentioned AI. And, I have no doubt that the physician that you spoke to is probably being driven by an AI generated algorithm that the insurance company has. And I think at this
No
point,
comment, but I'm shaking my head.
yeah,
Yeah.
I mean, I think at this point, the best thing we could do would be to develop an objective list from your perspective as a clinician of all things you mentioned, right? But objectively say how that impacts their health and kind of raise the bar for the need for intervention, clinical intervention,
Yeah.
and just create that.
Yeah, it's interesting. I'm speaking on a panel in about a month on just this, you know, how to use AI for good and what are we afraid of in medicine, how it can be used for evil, by our definitions, whether it's denying care or being used against patients or used against physicians. It's like AI everywhere. It's the absolute Wild West. Um, so yeah, that will be a lively, interesting discussion for sure.
Oh, I'm sure it will be. But thank you for sharing that. I feel terrible that you're dealing with that level of frustration, and your patients, I'm sure, are very grateful for all that extra,
Yeah, it's worth it.
obviously.
I absolutely. I mean, that's part of, I think, our commitment to patients is we do that and we
Yeah.
fight for them. Um, I think there's also a conception that, and maybe it was this way 30 years ago, but there's this conception that we make all this money off of these procedures. And I know physicians still are making a good living by um, really any standard, but it's a fraction of what physicians made 30 years ago uh, for doing a lot less, you know. And so I think there's this assumption that physicians are trying to do all these cases, and especially when patients see their explanation of benefits, the EOBs, and they see these exorbitant numbers on there that literally are monopoly money that has nothing to do with what the physician or the hospital is actually going to be paid. Um, I think there's just this misconception that, well, of course, my doctor can spend 3 extra hours a day doing this stuff. I mean, they're making tens of millions of dollars. No. Um, Primary care physicians and pediatricians, they don't make much more than our police officers, our firemen, our teachers who don't make enough. Let me go
Mhm.
on the record. My mother was a
Agreed.
teacher for almost 50 years and barely made anything. So I don't think people realize that. Surgeons make a little bit more, but it's about a tenth of what it for what we make now, our median income in otolaryngology, it's about a tenth of what it was in the 1990s, meaning we're
especially if you
making
factor in
90%
inflation.
less. Right?
Well, if you factor in inflation and all the costs
Yeah,
of running a
right. Without
practice,
even that, yeah. Yeah.
and that
Just
makes
the
it
actual number.
hard. It makes it hard to continue to get the best of the best going into the profession of
That's what I
medicine.
worry about, right?
Yeah,
We started this talk with the fact that you and I are still bullish on the best and the brightest choosing medicine, and I have people shadowing us, especially during this time of the year when they're off from school all the time. I never discourage people from going into medicine, but um, it's true if there isn't some economic opportunity, even if that's not the primary driver, those really bright, clever kids are going to choose something different.
yeah,
And medicine is just it's just different. It really requires brilliance and empathy and competency and ethics and morality that other professions, those are all wonderful, but they aren't required. In medicine, I feel like they're required. And so I hate when kids that a generation ago would have chosen medical school choose something else because of these inconveniences, these impediments.
obstacles. Yeah. No, I totally agree with you. And looking out into the future, I'd love to think of ways that we can excite um, people to go into medicine because it is an amazing career and you do get a lot of what I call psychic income, which are the rewards of
Yeah, like that. Yeah. Yeah.
of, patient relationships and knowing that you have that impact on a patient's life. There's nothing like it. I mean, there's
I
nothing else
don't,
like it.
yeah, you and I have never been lawyers, we've never been accountants or whatever, but I can't imagine the situations that you and I have had. I mean, where, that it happens all the time where patients just look you in the eye and have tears in their eyes and thank you for what you did. And a lot of times I don't even think what I did was that spectacular, but it really made a difference
For
in the
them, it
patient's
is.
life.
Yeah.
And so I take them at their word. Yeah, I just, maybe teachers get that kind of psychic income, maybe, but it's probably years later if people take the time to go back and thank them. But we do get that so many times. I mean, I think
Yeah. You get it
99%
all
of
day
the time.
long, and that keeps you going. And I
Yeah.
think the same is true in innovation, which I think will be a great lead into our next podcast because what I'd like to do, I mean, I know we spent a lot of time on the clinical aspects of your life, which is the majority of it, but you've been so active and amazing in your life as an entrepreneur and innovator. I think it warrants a separate conversation that I'd love to focus on if
Thank you.
you're
I'd
up
love to
for
talk
that.
about that further. And again, you are one of many who inspired me to do so. So back at you with all that you
Wow.
accomplished and that you're doing. But I'd love to talk about that further. In fact, this coming year is a year where I'm able to give back to one of my institutions, Vanderbilt in particular, and set up lectureships and eventually hopefully a course on the business of medicine and medical entrepreneurship.
Awesome.
So we'd love to talk about that in more depth because that's literally just coming to fruition as we speak.
Oh, that's
But
very
that's one
exciting.
thing I would say to your comment a moment ago is how do we get kids to still be interested in this? And I think it's that medicine is one of those fields where you can truly innovate and it's busy, but you can straddle the two different worlds like I do, where you can care for patients. Right now, I'm doing that about 60% of my time. And the other 40% using what I've learned caring for patients for 35 years to develop new technologies and to work on the business sides of medicine. And I love that balance. And
I
I
do
think
too.
that will always attract, I know you do. I think that will always attract, some of the best and the brightest that come behind us.
I do too. I really, it's it's just hard to describe in words how fulfilling both of those aspects of life can be. But you do need the combination of the knowledge and the experience.
Yeah,
to
yeah,
really bring to the
exactly. I
table.
mean, you deal with so many brilliant engineers like I do, but they've never done a physical exam, right? They've never, many times even stood in an operating room, let alone been over a patient where you are responsible for their well-being, their life, and had to make decisions like that's how you innovate. It's based, you draw from that experience where you've been over decades. And yeah, I don't know that there's anything else like medicine to afford you that opportunity.
I would agree. And I think if nothing else, hopefully that will inspire some really bright minds out there to take it on, you know, go
I hope so.
forward and have a really exciting and productive and fulfilling career in medicine and the next chapter, which is innovation. So
Exactly.
if you're up for it, I'd love to get that on the books
Always,
and open
always.
up that conversation because I'm sure that'll be really exciting as well.
I look forward to it.
Thank you so much, Heath, for sharing all of that with me. And
Absolutely.
let's
Thanks
work
for having me
on,
again.
oh, my pleasure. And let's work on figuring out how to create some objective criteria that will help with these obstacles and burdens in your patient care day-to-day routine. Because I think we have to fix that.
Yeah,
It can't go on. It's not a sustainable model. So, you know,
it's not. It's not. Yeah.
I think we can do it.
Okay, deal.
Okay. Thanks again, Keith.
Thank you, Gail.
Have a great day.